Good afternoon, everyone. On behalf of Sir Gangaram Hospital, New Delhi, and Delhi Liver Foundation, we warmly welcome you all to the 28th Conference of ILGPS Clinics in Hepato-Biliary Diseases 2025. We are honored to have with us leading experts, colleagues, and young minds who are shaping the future of gastroenterology and hepatology. This conference is not just an academic event, but a platform for exchange of knowledge, collaboration, and inspiration. Over the next 2.5 days, we will be hearing from eminent experts who will share their insights on the latest developments, clinical practices, and innovations shaping the future of hepatology and gastroenterology. With that, let us begin this journey of learning and academic exchange.
Now I would like to invite the organizing secretary, Dr. Ashish Kumar, to please come onto the stage and welcome everyone.
Good afternoon, everyone. So, on behalf of the organizing committee, it is my great pleasure to welcome you all to the 28th Annual Conference of Clinics and Hepato-Biliary Diseases 2025, which is being organized like every year by Sir Gangaram Hospital under the aegis of Delhi Liver Foundation. So, as you all know, over the years, CHBD, as it is commonly known, has become a brand itself. It is recognized and loved by the practicing gastroenterologists across the country. And what sets the CHBD apart from other meetings like what you attend, like ISG Con, INASL, SGI, is its grounding nature. Here, the focus is not much on the future research, but addressing the common day-to-day problems we face in our clinical practice. And it is this practical problem solving approach that has made CHBD immensely popular year after year. So this year's scientific program has been carefully designed with the two aims: to bring the latest updates in gastroenterology and to address the real world challenges in clinical practice. So over the next 2.5 days, we will cover the full spectrum from luminal disorders, GI disorders, biliary and pancreatic diseases, hepatology, GI motility, diagnostic and therapeutic endoscopy, endoscopic ultrasound, and also the cutting-edge advancements in the third space endoscopy. The program will feature lectures as well as debates, case-based discussions, which would be led by leading national as well as international experts. And we have also strived to keep the sessions interactive with ample room for questions and discussions. So before we begin, here are a few housekeeping announcements. Kindly keep your mobile phones on the silent mode to avoid disturbance during the session. A gentle request to distinguished speakers, please conclude your presentations within the allotted time so that we can have adequate time for interactions and discussions. Moderators are requested to initiate the discussion at the end of the session and not after each talk, except for a few of the sessions where there's only one talk. And members of the audience are requested to please identify yourself before asking questions and use the standing mics which are provided in the aisle. Moderators and chairpersons are requested to end the question answer session as the timer runs out. So with this, I once again extend a very warm welcome to each one of you, and I'm confident the sessions ahead will be both academically enriching and practically useful to all of you. So let us begin CHBD 2025, and I request our anchors to initiate the first session.
To begin our first session, we would like to invite on stage the moderators, Dr. Pallavi Garg, Dr. Mahavir Sharma, Dr. Manoj Saha, and Dr. Sanjay Goja to conduct the session.
I would also like to invite our chairpersons, Dr. Ajay Prasad, Dr. Muzaffar Shaul, Dr. Harshdeep Sahni, Dr. Pradeep Kafle, to kindly chair the session. I request Dr. Vijay Mohan Prasad, the speaker for the session, to kindly come onto the stage.
Over to the chairpersons. Should I start?
Yes, sir. Yeah, it's really good. Yeah.
Thank you so much.
Gastroenterology start.
Thanks, respected moderators, chairpersons, and my dear friends. I think first of all I should have a quarrel with Anil Arora because he wanted me to have food. So it becomes very difficult for a speaker to speak after food. No, you should speak first. That means I can speak only very little. Good. So I had a good sumptuous lunch. Thank you so much. Thanks to Anil and Ashish and the entire team, Sir Gangaram, for inviting me to deliver this talk on a brand new arena for me. So how many of you are masters of allergic food disorders? Please put up your hands. I can't see any hand. So you're all sailing in my boat. Okay, let me see at the end of my talk whether I'm able to pass on some good info. Now, friends, please gear up. We are into a space journey. So we are going to explore an unexplored area as far as gastroenterologists are concerned. So now, this is called the food intolerance test. This is a young gentleman who came to me. These are all the allergies. So this is what we do. So commonly, you're all doing food tolerance tests? How many of you are doing food tolerance tests? Please put up your hands. Yeah, many of us. And this is absolutely different from what I'm going to speak to you. That is IgG driven. But now we are talking about something else. So the food intolerance is like Trump, whereas the food allergy could be as bad as the other guy. So it could be life-threatening. So please remember, this is an irritant factor that could be life-threatening. That is the difference between food intolerance and food allergy. Right. So how do you differentiate? What are the differences? The mechanism in food allergy is immune-mediated, whereas the food intolerance is non-immune. Onset here, it is generally, if it is like an anaphylaxis, it could be immediate. Sometimes it's delayed. In food intolerance, always delayed. Diagnosis is serum total IgE, but even better tool is antigen-specific IgE, what we remark by yes IgE, or a food challenge. The other thing is exclusion or re-challenge. Common types are shellfish and nuts, and here lactose and FODMAPs. I would like to draw your attention to this, one of like the Bible, still, which was published by the United States 10 years ago or so, but still holding the fort. So, when to suspect food allergy is the diagnosis of IgE-mediated food allergy, diagnosis of non-IgE-mediated reaction, conclusion and key takeaways. This is what I'm going to discuss today. About 4 to 5% of our population have food allergies, and it's increasing. Say, for example, somebody gets exposed to the allergen, it gets sensitized, then the cell-mediated immunity is in play here. And then also the IgE can also trigger a response. So it is IgE mediated or cell mediated, which is non-IgE mediated, and then mixed. Symptoms indicating food allergies are urticaria, angioedema, and pruritus. In GI, nausea, vomiting, diarrhea, abdominal pain. You would think that it's an acute infectious gastroenteritis, but it could be a severe problem because of food allergy. So the timing of the food-induced allergic reaction should be determined. Immediate is minute to hours, typically IgE-mediated. Delayed is cellular. IgE-mediated, common in young adults and atopic disorders. Non-IgE-mediated, chronic GI symptoms. Mixed can be there. Many of the eosinophilic disorders have both bases of IgE mediation as well as cell-mediated. And so, so the role of the gastroenterologist becomes a challenge. You need to differentiate allergy from intolerance, functional GI disorders, and infections. And you'll have to recognize eosinophilic GI disorders, and you'll have to coordinate with allergy specialists. So food allergy is divided into IgE mediated, like oral allergy syndrome is by far one of the commonest in this group. And here is non-IgE mediated, you have eosinophilic, food protein induced enterocolitis, FPIES, FPAP, and then there's a GERD constipation, all this food protein induced. Here, this eosinophilic disorders are mixed. So IgE-mediated oral allergy syndrome, it is because of cross-reactivity between the pollen and the food, like raw fruits. And these are all the pollens which could have some bearing to the antigens in the fruits or nuts. They can trigger response. 4% of IBS patients have allergy, they're being missed. And mixed IgE and cell-mediated are mainly the eosinophilic disorders. You all know eosinophilic disorders. I need not revisit that. And then you have the EGIDs. Non-IgE mediated disorders are the food protein induced enterocolitis syndrome, what is called FPICE. We should know about it. So acute onset, 1 to 4 hours, trigger food after an ingestion of trigger fruit. It just typically presents like an acute infectious gastroenteritis. So shellfish is by far the commonest. Then soy, nuts and dairy can also produce. Diagnosis is based on clinical history and symptom pattern, which means we have to take a proper history. Then only we can diagnose food allergies. And no specific blood tests or biomarkers here. Oral food challenge is the one that confirms. And if you see the food protein induced enteropathy syndrome is a chronic disorder. That one is acute, this is chronic. Again, we need to do biopsies, and again, food elimination and re-challenge is the way. This is a FPICE and enterocolitis syndrome. So you have to, what is called the offending food challenge is what we do. So that is important. So if it is negative, then you have to follow up. If it is positive, that confirms the FPICE. Then there is something called allergic proctocolitis, which resembles IBD, ulcerative colitis. There is a rectal bleed. So here again, the diagnosis, colonoscopy, biopsy, rule out IBD infections, hemorrhoids, symptom resolution on elimination diet confirms the diagnosis. So you need to have a real thought process there. So, and non-food, the differentials are drugs and insect stings and AD flares, irritants, humidity, bacterial infection, staphylococcus aureus, or chronic GI disorders like reflux, infection, anatomic issues, lactose intolerance and others. So DD is like tart foods, food poisoning, EGID, alternatives like parasites, reflux, all those has to be remembered, and behavioral and pharmacologic and allergies. So now, how do we diagnose a food allergy? So IgE mediated food allergy, history taking, examination, confirm the parent or patient reports, SPT, that's a skin prick test, and the antigen specific IgE, not the total IgE. It's no use. Elimination is good, challenges are the best. So avoid non-standard tests. So skin prick test, this is what we do. Any VL above 3 millimeters is specific, and intradermal tests are not useful. Total serum IgE not useful, and antigen specific IgEs, SIgE, is useful, especially for milk, egg and peanuts. These are by far the commonest where they test. And A to P patch test also not useful. Component resolved diagnostics is the way to go. That is the future. So here it is a modern allergy test technique that analyzes the immune system's response to individual allergen components. That is the specific proteins rather than the whole this thing. So this is the peanut, egg, milk, tree nuts and wheat. You have all these allergens. Combination tests are not generally useful, and role of elimination diet and re-challenge is the way to go. And food elimination diets, that I'm not dwelling upon it for want of time. So these are all the protocols. Oral food challenges are the best. Elimination can help, but oral food challenge will demonstrate that is a gold standard. So this is what we have to do. The double-blind placebo-controlled, challenge, food challenge is probably the best. So these are the diagnostic tests. IgE, you can depend upon skin prick test and antigen-specific IgE, allergen-specific IgE. And component resolved diagnostics is evolving very well. Oral food challenge is the way to go. So non-IgE mediated, this is the way. And this is the key takeaway, is all these, references are there. Food allergies are uncommon, but important in GI practice. Testing has limitations. History and challenge, food challenge are the key. Collaboration with allergy specialists improves outcomes. Don't confuse intolerance with allergy. These are all the life-threatening and milder allergies. And I would like to dwell upon the diagnostic tools. skin prick test, serum specific IgE, then oral food challenge. So these are the ways to go. So suspect food allergy based on symptoms, history taking and associated disorders. IgE is useful for IgE mediated food allergies. Use skin prick test or selective SIgE for sensitization and challenges for confirmation. Non-IgE elimination plus challenges, and then biopsies for EGIDs. Avoid non-standard tests, confirm self-reports, benefits prevent reactions, improve the quality of life, and overdiagnosis leads to malnutrition, and future standardized tests improve predictive outcomes. I thank one and all for this opportunity given and the patient listening. I'm sorry for want of time I couldn't go through in detail, but I've given a bird's eye view of all the tests.
The house is open for any questions. Let me ask one question. Do you think over the time the food allergies have increased? And if so, what are the reasons? And also, do you think we have a mix like IBD plus allergy? So how do we actually deduce? How much actually takes time to somebody to come to the conclusion at the end it is food allergy? And in the beginning you said sometimes it can be lethal, or it is allergy. So if you give a exposure test to somebody, so how safe is it?
Absolutely. So this is my 39th year of gastroenterology. I'm like a learning child when it comes to question of food allergies. So we need to have a high index of suspicion and a proper history taking. History taking is the paramount important thing to do in life. And the question of how safe is the re-challenge testing that has to be done in an institution. And if somebody presented to you with acute food allergy like anaphylaxis, like reaction, please do not do the re-challenge test. It is very dangerous. So you'll have to again start with a low dose under observation, under admission, slowly increase the dose and reach the standard dose of food allergen that is consumed to see the reaction. And then you should be ready with epinephrine and hydrocortisone, everything, and antihistamines, and the entire team to resuscitate should be ready if you're running a food allergy, re-challenge test. Elimination is okay. Elimination, okay, you stop it, then you don't get it, okay, over a period of observation, 1 month, 2 months you observe, you don't get it back, okay, that's, it's sort of okay. But to establish gold standard is oral food challenge, OFC. That is little tricky, you have to be careful. Sir.
So, excellent. So, I've got 3 questions. Number 1, in a patient of irritable bowel syndrome, IBS, when would we suspect food allergy? That is number 1. Second, you said that skin prick test. Obviously, we gastroenterologists don't do. So, we would need help from
Allergists.
Another question, if we do find someone with allergy, maybe to nuts, so can we treat it or it's just for life?
Yes. No. See, we started doing the allergy skin test 35 years ago with the allergen. So, but multiple allergens have to be injected in the skin and then the veal reading has to be taken. And then what we do is we desensitize the person for that this thing. So what happens is the anti-allergy serum has to be prepared. The allergy specialist, allergists prepare it and then start injecting. You'll have to inject 3 times a week for 52 weeks. So somebody who's ready for that only can go through that.
When do we suspect in IBS?
IBS, absolute difficult question. So what I do is if somebody presents with IBS, I treat him and then see what happens. Like it could be many a times, PI-IBS is very common in India, as you know, post-infectious IBS. So that will be by far the commonest. Because food allergy is only 4%. Out of 100 people, if you see, it's only 4%. It's not talking about 40%. So you need to probably, once you treat with the standard of care, and then these persons, many of them are intelligent. They'll say, doctor, whenever I take this tomato, I get this problem. Then you say, okay, stop it, observe, then again have a food challenge, then see what happens. Many of them are not life-threatening, as in IBS, they're chronic. Sir. Well,
There is a recent article, but the article is in press, in Gastroenterology. That's all.
see, this is, I think, a private, info to Sharmaji, where I don't have any knowledge on that, whatever article. But then I think DGBI has less role to play in food allergies because you are looking at some allergen which is already sensitized the gut and then on re-challenge is triggering either an IgE mediated response or a cell mediated response or a combo. So I think the DGBI role will be probably less here.
Yeah, excellent talk, Dr. Mohan. My question is it that the additives, polishing agent, taste enhancers, or color enhancement is adding to the allergy, or is it all because of nascent food? As you very rightly said, this food allergy is supposedly increasing. Dr. Adrian is going to talk on environmental effects on these GI tract diseases. But is it that that is contributing far more rather than the raw fruit which our ancestors had been eating in the past?
Absolutely well taken analogy. I think that's what is happening because many of these additives can have a molecular mimicry. So our system keeps thinking it's a foreign antigen and keeps fighting. So your point well taken, sir.
Where do you fit in non-celiac gluten intolerance into your scheme?
Sorry, come again.
Where do you include non-celiac gluten intolerance in your scheme?
In allergic disorders?
Well, in your whole scheme of food intolerance.
Well, of course, it's a food intolerance rather than if you take it as allergy, then it's not under the list. The celiac is not listed here, but we all know it's a gluten sensitive enteropathy or gluten induced disease, which is again immune, but it's not listed in this disorders.
No, I'm referring to the non-celiac gluten.
Oh, non-celiac
problems.
gluten sensitive, not included in the list in the allergy food allergies.
So how do you deal with it?
Yeah, you'll have to eliminate gluten. That's it, as simple as that. We don't see in South much because we are not wheat eaters, and only when we migrate to US, then we develop celiac. Our South Indians.
Okay, thank you.
One last question. So we get a lot of these commercial tests which are available. They test for 256 different allergens.
Correct.
Some will test for 10 allergens. In fact, some are doing IgG-based tests rather than IgE-based tests. So what's your recommendation in terms of, and what taters do you use? Because some of them will come with high taters, some of them will come with low taters, cutoff taters. So it's a real practical issue actually, more than
No, if somebody has only intolerance, like IBS or dyspepsia or some diarrhea, mild diarrhea on and off, you can do that intolerance test, tolerance test. Or on the other hand, if somebody reacts, like allergy, itching, rashes, edema.
patients actually come in with these test results done by this and this lab, German labs, is that they're testing a lot of things, about 500 different
Yeah, whichever is above that 0.5 or 5 or something like that, the cutoff, maybe you can try, ask them to eliminate that, make a diary, re-challenge, and then if it is really producing a botheration, then they can
Thank you, sir, for excellent talk.
Thank you so much once again.
Thanks for the wonderful session, sir.
To begin our second session, we would like to invite on stage the moderators, Dr. Vibhu Mittal, Dr. Amit Sachan, Dr. Kim Waife, Dr. Chirdeep Agarwal, Dr. Amit Bhasin.
And I would like to invite chairpersons, Dr. Piyush Mishra, Dr. Rupesh Sreshta, Dr. Wasif Amali, Dr. Hitendra Garg to please chair the session. And for the first talk, I would like to invite our speaker, Dr. Rinkesh Bansal, to the stage.
So good afternoon, everyone. It's obviously nice to be a part of this conference, which is in our deep heart. So my topic assigned was FODMAP diet in IBS, hope or hype. Interestingly, we all know about the IBS and FODMAP, and regarding the irritable bowel syndrome, we know that it's a functional disorder which is diagnosed with the ROM4 criteria after ruling out of a organic disease. It has categorized as the IBS diarrhea predominant, constipation predominant, or mixed, or sometimes it's unclassified, with the most common, most prevalent is IBS diarrhea predominant in half of cases. So according to ROM4 criteria, the recurrent abdominal pain on average at least 1 day per week in the last 3 months associated with 2 or more of the following criteria related to defecation or associated with change in frequency of stool or in the form of stool, appearance of stool. This criteria fulfilled for the last 3 months with symptom onset at least 6 months prior to diagnosis, defined as a irritable bowel syndrome after ruling out organic disorder. So in my talk, the agenda is we need to understand the pathophysiology of IBS. We need to understand the FODMAP. What are the evidences? What are the guidelines which guide us? Who respond and who don't? And what are the safety and microbiome and nutrition related teach? And is there is hope or hype? Regarding the pathophysiology, there are some biophysiological disorder because of gut-brain axis dysregulation and because of visceral hypersensitivity. In like last talk, there is a well-known entity post-infectious IBS in which there is a immune activations, barrier dysfunction, and as well as bile acid malabsorption. The motility disorder sometimes along with gas handling can cause IBS, and there are well-known dietary triggers which causes the luminal distension and causes the nerve activation which cause pain. So what are the FODMAPs? So FODMAPs are the fermentable, oligosaccharides, disaccharides, and monosaccharides and polyols. So there are different component in our diet. So why this FODMAP is a big noise? Because it can cause, it's a short chain carbohydrates. So it's poorly absorbed in the small intestine. Because of this FODMAP, there is a high osmotic load in the intestine which is causing the water retention. The rapid fermenters like hydrogen or methane or CO2 along with short chain fatty acids formations causes the luminal distension and causing the symptoms of diarrhea or pain or bloating. So individual threshold vary. Adaptive effects of multiple FODMAPs can be happen. We know in the high FODMAP diet can cause the breath of hydrogen rises in irritable bowels. There are well-known cofactors like anxiety or stress, dysbiosis, SIBO. So test and tailor rather than the permanent restrictions is the key for managing IBS. This is a long list of FODMAP diet. There are in right side there is a high FODMAP food, in left side is a low FODMAP. We all know that in the each category of like oligosaccharide, disaccharide, monosaccharide and polyols, there are the options of high FODMAP versus the low FODMAP. And in a patient, we suspect that there is a irritable bowel because of dietary things. We need to avoid this high FODMAP in a systemic manner. So there is a protocol called MONAS protocol for low FODMAP diet. There are 3 phases. First phase is the elimination phase for 2 to 6 weeks, in which with the strict dietary supervision, we need to avoid the low mode FODMAP, high FODMAP. It should be strict but nutritionally adequate. The protein and other things should be managed. And next phase is the phase 2, in which the structure reintroduction of the single FODMAP to map the tolerance is allowed, and phase 3 is the personalization, in which we liberalize diet to maximum variety of while minimizing the symptoms. We should take care of the soluble fibers, stress modulation, exercise and probiotic during the reintroduction phase. So who is the ideal candidate? The patient who is a IBS diarrhea or IBS mixed, The typically meal triggered bloating, pain or diarrhea. When there is a dietary history, there is a high intake of high FODMAP like onion, garlic, wheat or legumes. The patient who are motivated, able to engage with dietitian and short-term trial acceptable. We should use cautions in patients with malnutrition, underweight, pregnancy, pediatrics. We should screen the celiac disease, which is quite common in North India, and we should do a fecal calprotectin also to rule out IBD. In IBS-C, we should consider fibers, fluid and osmotic first. FODMAP may help bloating but less effect on constipation. So basically, it should be tailored approach. Regarding the evidence, yes, we have evidence. There are multiple RCT, there are network meta-analysis. So in guideline, ACG 2021 recommended the limited trial of low FODMAP. These are the key trials. These four important trials I have mentioned is, first is a HARMOS trial, randomized trial of around 30 patients, low FODMAP versus typical Australian diet, and there was good outcome with overall GI symptoms. Next, Bonds, who also, there was a low FODMAP versus traditional dietary advice, both improved, but there was no significant difference. There were some other also which showed some benefits in symptomatic control only. There were some other guideline like network meta-analysis GUT 2022, in which low FODMAP ranked highly for global symptom relief. So mind it, it's for the global symptom relief, it's not for the disease cure. Systematic review up to 2024 also shows that there is a 50 to 70% of response rate with greatest gain in bloating or diarrhea. So this is a widely quoted review articles of 13 studies, 6 RCTs, 7 mixed studies, less than 100 participants. But what was the important in this study, that there are positive like GI symptoms were better, but there was negative effect, negative things also, like diet was quite complex. Easily it cannot be managed for long term, required training by a specialized dietitian. And there is a bacterial dysregulations also. Another meta-analysis by M.I.C.E, which is a 22 studies including 6 RCT, and there was significant decrease in the score, but and there was significant improvement in quality of life, but there was pooling of data was a challenge because it's a quite heterogeneous populations, and there was a lack of adherence figures across the studies. Again, potential adverse effect on gut microbiota were there. So there is a issue with microbiome. There is a issue with nutrition. So when we give a blanket statement that we should restrict the FODMAP, we should consider that short-term low FODMAP diet can reduce the bifidobacteria, which is quite important. We should consider co-administration of multi-strain probiotic during or after eliminations, and we should preserve probiotic fibers where tolerated. We should also monitor and supplement the nutrients, use lactose-free dairy, firm tofu, low FODMAP diet, and avoid long-term strict LFD to protect microbiomes. Regarding the Indian data, we have high FODMAP diet, specifically in our this regions: onion, garlic, wheat, atta, rotis, rajma, chana, mango, apples. These all are high FODMAP diet. What we can do, we can use like hing instead of onion, garlic. We can have a green part of spring onion. We can use multigrain or rice, jowar, bajra. Meal portioning also matters. Meal patterns also matters. So we should educate on the portion size. So what the evidence says, what's the hope? Yes, there is a 50 to 70% symptom improvements. Effective in IBS diarrhea and IBS mixed type, reduces the bloating, pain, diarrhea, urgency, and major guidelines support it. But what is the limitations or what is the hype? It's not a cure, it's a symptomatic management. We are restricting diet. There are some nutritional deficiencies. Gut microbiome again have negative impact because of this diet. Strict dietitian supervision is must, and it's not effective for all patients. Obviously, the stress and gut-brain axis we should keep in mind. So common pitfalls, obviously the nutritional and microbiome harm. Over-restricted use, again, it's a issue. Ignoring non-dietary drives like stress, sleep, pelvic floor, and other things, we should consider that also. And we should rule out the other disease prior to put in on this diet. What is the balanced view? We should have strong evidence, significant relief for many symptoms, but as oversold as a cure, it's not a cure. So it's a multimodal IBS management in which one of the part is low FODMAP diet, and obviously the personalization is the main key. To conclude, low FODMAP diet is a evidence-based, effective for many IBS patients for symptomatic control. It should be dietitian supervised, time limited and individualized. More hope rather than hype, but not a one size fit for all solutions. So take home message from my presentation, ladies and gentlemen. Low FODMAP is evidence-based and effective for many type of our IBS, but not for all. It's not a cure. Best result with the time-limited elimination, structural reintroduction and personalization. It should be used as a multimodal care with other factors, and dietitian's partnership is essential. More hype than hype when applied correctly. Thanks a lot for patience hearing.
Thank you, sir. Question answers will be taken after second talk. Yes, yes. So now I would like to call on the stage second speaker, Dr. Munish Agarwal, for the second talk of the session, Dyssynergic constipation. And the question and answers will be taken after the session.
Good afternoon, everybody. At the onset, I want to thank Dr. Anil Arora, Dr. Sheesh, and Dr. Praveen for calling me here to give a talk of very pertinent topic of dyssynergic constipation. Before going to dyssynergic constipation, we should know the physiology of defecation. Defecation is spinal reflex. There is extension of the rectum, which causes reflex contractions of this musculature, and there is desire to defecate. We have the internal group of muscles, which are smooth muscles. They are supplied by sympathetic and parasympathetic innervations. We have the external group of muscles, which are skeletal muscles and which is supplied by the motor nerve of pudendal nerve. In this diagram, we can see when the rectal pressure rises above 18, there is a urge to defecate. Above 55, there is a defecation. At rest, there is a relaxation of the rectal smooth muscles. There is a contraction of puborectalis muscle, which maintains the angle of 90 to 100 degree. And there is a contraction of the internal and external sphincters, which maintains continence and avoid defecation. But during straining, there is a contraction of the rectal smooth muscles. There is a relaxation of puborectalis muscle, which results in perineal descent. And there is a relaxation of internal and external sphincter muscles, which promotes defecation. Here we can see there is a parasympathetic, sympathetic, and motor innervations of the various muscles involved in the defecation. Sympathetic nerves basically cause relaxation of this rectal smooth muscles, and contraction of the internal sphincters thereby promotes continence and prevents defecation. But on the contrary, parasympathetic fibers causes contraction of the rectal smooth muscles, and relaxation of internal sphincter muscles causes defecation. Then we have the motor nerves or pudendal nerve, which basically contracts abdominal muscles, which and relaxes this puborectalis muscles and relaxes external anal sphincter, which is a skeletal muscle, and promotes defecation. Constipation is a very common clinical problem all over the world. There is a serious impact on the quality of the life of the patients, and there is a big financial burden. It is said that almost 2.5 million individuals with constipation undergo evaluations annually. There is almost $500 million which is spent on the laxatives each year. The traditional definition of constipation has been less than 3 bowel movements per week. ACG Task Force defines it as an unsatisfactory defecation characterized by infrequent bowel movements, difficult to pass stools, or both. But objectively, it's defined by recent Rome 4 criteria. If we talk about epidemiology, the prevalence of constipation is almost 14%. It's based on meta-analysis of 41 studies with over 2.6 lakh subjects throughout the world. The common factors which predispose to constipation includes advanced age, female gender, low level of education, low level of physical activity, low socioeconomic status, multiracial ethnicity, low use of certain medications. If we talk about of types, we have the functional, which is more common, 80%, organic 20%. There is a big list of organic causes. I will not go into detail. If we talk about functional constipation, we have the normal transit constipation, almost 60% cases, slow transit constipation, almost 25% cases, defecated disorders, 13%, and mixed, 3%. So in this presentation, I will basically giving importance to the defecatory disorders. What are the diagnostic criteria for dyssynergic defecation? Patient must satisfy the diagnostic criteria for functional constipation. Patient must demonstrate dyssynergic patterns from type 1 to type 4 as defined by the paradoxical increase in the anal sphincter pressures or less than 20% relaxation of resting anal sphincter pressures or inadequate propulsive forces observed with manometry, imaging, or electromyographic recordings. Patient must satisfy one or more of the following criteria, that is inability to expel artificial balloon that contains 50 ml of the water-filled balloon within 1 to 2 minutes, or inability to evacuate or more than 50% retention of the barium during defecography. So causes of this dyssynergic defecation includes childhood causes almost 31%, post-pregnancy 29%, and unknown cause 40%. We should be alert to see the manifestation of depression, insomnia, lack of energy, loss of interest in the life, loss of confidence, and sense of hopelessness in these patients. In one of the studies, there is almost 22% patients they have sexual abuse and 32% they have physical abuse. We should look for the various alarming factors like weight loss, rectal bleeding, recent change in the caliber of the stools, abdominal pain, or family history of the colonic cancer. Now this is important, how to differentiate between functional, organic, and dyssynergic defecation from the history. In the functional, you have the long-standing symptoms, no constitutional symptoms, no bleeding mass, no symptom of obstruction. Organic, you have the recent onset, loss of appetite, loss of weight, there is a bleeding and the mass, there is a history of colonic cancer. Dyssynergic defecation, you have heaviness in the perineum, excess straining, feeling of obstruction, distal evacuation and sport of the perineum. If we talk about distal rectal examination, it has got a very high sensitivity of 75% with 87% specificity for identified dyssynergia, and positive predictive value was 97%, which is quite high. Paradoxical contraction of the external anal sphincters and the puborectalis muscles with fingertips being displaced anteriorly during tempted defecation is suggestive of dyssynergic defecation. Various investigations are to exclude the systemic and structural causes, to detect underlying cause. If patient is unresponsive to simple treatment, young patient without alarm features can be treated empirically after thorough history taking. Patient with alarm features mandate Dwarka, which includes to look for ESR, complete blood counts, biochemistry profile, sugar, thyroid function test. You can go for X-rays and even for barium anemas. We have the colonoscopies, which should be done in case there is a history of bleed, there is elderly patient, weight loss, obstructive symptoms are there, recent onset of symptoms are there in case patient having iron deficiency anemia. We have the various tests for functional constipation, which includes radiopaque markers, wireless motility capsules, scintigraphy. If the markers are retained exclusively in the sigmoid colon rectum, then patient may have a defecatory disorder. In the scintigraphy, we have the two methods of indium 111 DTPA labeled water consumed in a standard solid liquid meal, or indium 111 activated charcoal slurry. You can see in this diagram the radioactivity in the healthy controls and constipation controls at 24 hours and 48 hours. Now this is important. What are the various types of dyssynergia? We have the type 1 dyssynergia based on the anorectal manometries. In this, the patient can generate an adequate pushing force, but there is a paradoxical increase in anal sphincter pressure, resulting in constipation. In type 2, patient is unable to generate an adequate pushing force, but can exhibit a paradoxical anal contraction. In type 3, the patient can generate an adequate pushing force, but there is absent relaxation or incomplete relaxation of the anal sphincters. In type 4, patient is unable to generate an adequate pushing force but demonstrates absent or incomplete anal sphincter relaxation. Now, balloon expression test is important test to diagnose dyssynergic constipation. Is a 4 centimeter long balloon filled with 50 ml of warm water and placed in the rectum. After placement, patient is given privacy and asked to spell the balloon. Stopwatch is provided. It is a useful test for screening of the dyssynergic defecation. Sensitivity is 50%, specificity is almost 80 to 90%. Then we have the defecography, in which 150 ml of barium is inserted into the patient's rectum. The drawbacks are radiation exposure, embarrassment, limited availability, interobserver bias, or inconsistent methodology. The various defecographic pictures of patient with resting, squeezing, straining on defecatory patterns. Then we have the MR defecography, and this is again of the patients in the resting phase, squeezing, straining, and in defecatory disorders. Multiple test positivity, including balloon expression test anorectal manometry and diffeography has better accuracy than a single test for functional evacuation disorders. If you talk about the treatment, there is a time toilet training. We should attempt it. Defecation should be done for 5 minutes, 30 to 60 minutes after the meals twice a day. Each position should be in the squatting position. Physical activity, increased water intake, and dietary fiber should be taken. Then we have the various bulk laxatives like psyllium, methylcellulose, and polycarbophil. We have long list of the laxatives we all know: osmotic, stimulant, stool softeners, enemas, chloride channel activators, guanide cyclase agonists, 5-HT4 agonists. We have some future agents like chinodoxycolate and ilobixibat. We have one of the bar diagram which shows that the prosecretory agents are most effective. Then there are various guidelines from American College of Gastroenterology and World Gastroenterology organizations of the various laxatives, which shows PEG and the prochlorperoxide, which is most effective. Then biofeedback therapy is very important, corrects dyssynergy and coordination of the muscles, enhance rectal sensory perception. We have the rectoanal coordination, in which subject is seated spine in a spine position, and patient is asked to take a good diaphragmatic breath, and patient can see the various manometric patterns seen on the monitors. Then we have the simulated defecation training program, in which again 50 ml of the water-filled balloon is inserted in the rectum, which acts as an artificial balloon, and which patient is asked to expel the balloon. Then we have the enhanced rectal perception, which we inflate the balloon, we increase the volume of the balloon till the patient has urge to defecate, and we can repeat it multiple times, and we can reduce the volume of the balloon later on by 10%. Now, these are the various phases of biofeedback therapy, symptom assessment, to which we should explain the physiology of defecation and pathophysiology of dyssynergic defecation, diaphragmatic breathing exercises, timed toilet training. Phase 2 is active phase, which includes visual, auditory, and verbal feedback mechanisms. Phase 3 is a reinforcement. The various trials which are available, which all shows that this biofeedback therapy is more effective than other agents. We can see the efficacy is between 70 to 90%. This is one of the diagram which shows that before biofeedback therapy, there is increased rectal pressure and increased renal pressure, but after biofeedback therapy, there is increased rectal pressure, but there is a fall in the renal pressure. This is the last slide, which shows how to approach a patient with chronic constipation. We should confirm the constipation, we should rule out the secondary causes, lifestyle modification should be done. And there is no response, we should give laxatives, stool softeners. Again, there is no response, we should go for various tests like balloon exposure test, anorectal manometry, diffeography. If they are negative, structural disorder should be sought of. If there is positive, we should think of functional disorders. Both abnormal means there is a dyssynergic defecation, biofeedback therapy should be offered. And in case there is one test is abnormal, we should go for clonic transit studies, MR diffeography and EMG, NCV studies. And if both are normal, we should go for clonic transit studies. If it's normal transit constipation. Abnormal means slow transit constipation. Thank you for your patient hearing.
Thank you, sir.
Dr. Agarwal, I have a question here, this side. What would be your thoughts for a person who is practicing in the periphery who does not have access to all these equipments?
I think at that time, if you don't have all the tests available in the periphery, the history taking is very important. A long history of perineum, history of fullness in the perineum, and so all this history should be taken care of. We should take a detailed history, and number of the points from the history can tell you that patient is having a defecative disorders, dyssynergic defecation.
Any comment from the floor? If none, the chairpersons, you all want to add anything? You want to say anything?
One question regarding the low FODMAP. So is it similar to basically a chronic food intolerance type? Like we are trying to tackle the chronic food intolerance and introducing a low FODMAP diet?
Yes, in a sense, yes. We can use the most common allergens in like food intolerance. There is a science that most of the food intolerance are the high FODMAP diet basically. So we are selecting that high FODMAP diet to reduce that allergens to the gut, and so that the symptoms will improve in this hope.
Okay.
Yeah, please go ahead. Introduce yourself, please.
I would like to know regarding the dyssynergic constipation. It was mentioned that pregnancy is responsible for approximately 31% cases and 40% are idiopathic and remaining of childhood. So, do pregnancy-related childhood-related dyssynergic constipation improve after a certain period, or we go have to intervene
No, all these causes, irrespective whether it's a pregnancy related or childhood related, they all improve with the biofeedback therapies. Biofeedback therapies has been shown to be useful in all types of dyssynergic constipations. And of course, after the delivery of the pregnancy, the patient will definitely improve and itself. But if the patient doesn't improve even after the pregnancy and delivery, I think biofeedback therapy should be offered. In the children, we should identify the causes in the children which are causing all this, because a lot of physical stress, there may be some stress in the children, psychological stress. We should take care of that. And most of these patients, they respond after taking all these causes. But still, if they have all these symptoms, we should go for biofeedback therapy, which is effective in all such causes, whether it's childhood related causes or pregnancy related causes or any other causes.
I think, yeah. Any? Acha. Okay. This should be.
Yes, this is there, because do you have the causes there post delivery, so patient will improve of itself in the childhood also. If you take care of the causes, identify the cause in the childhood, and if you take care that, the patient will improve itself even without the biofeedback therapy.
Achha, please go ahead.
Can I just ask about low FODMAP diet? My understanding is milk and wheat free diet is as good as low FODMAP diet, and it's a lot easier to implement. What's your take on that?
So in low FODMAP diet, obviously the lactose is not a low FODMAP diet. So lactose free dairy products we can use as a low FODMAP diet.
I'm just saying, instead of going with low FODMAP diet, if you just ask the patient to go on wheat free and milk free diet,
yeah,
isn't that as good as low FODMAP diet?
No,
in general, in terms of results.
Yeah, so we all know that gluten and lactose is the most common allergens. But there are some other element also which are the high FODMAP, but which are not the part of these two. Okay, so in nutshell, in low FODMAP diet, we should avoid gluten and lactose along with other high FODMAP diet also.
Okay, I think that should be the last. I think we stop here. Thank you very much. Thank you, everybody.
For our third session, we would like to call upon the stage the moderators, Dr. Wasif Ali, Dr. Pankaj Tyagi, Dr. Vivek Raj, Dr. Jatin Agarwal, and Dr. Ankita Gupta.
And as chairperson, Dr. Gaurav Gandhi, Dr. Balwant Singh Gill, Dr. Vijay Sharma, Dr. Dinesh Agarwal, Dr. Sagar Podial. And for the first talk, I would like to call Dr. Rupa Banerjee.
Welcome, Dr. Banerjee. We look forward to your talk. This is a very common problem, and I think something that we really would like to hear your opinion, because this is something that's a real life issue, and we get dietitians giving different advice, we get different doctors giving different advice as far as diet is concerned. So we look forward to your talk, please.
Thank you so much. Good afternoon, everybody. And at the outset, of course, I must thank Dr. Anil not only for inviting me, but for organizing this very clinically relevant academic program year after year. I always enjoy attending. My talk today is on emerging perspectives. And I'll just tell you how we have emerged as far as diet is concerned. There was once upon a time, an ideal time before time and geography, and we can all feel that. And then we made progress. There came industrial revolution. Just look at the thing. This is the factory, the Borsig Mechanical Engineering plant, where the first steam locomotive of the world was built here. But at the same time, if you notice, this is the first vivid description of belching smokestacks and air pollution. Post-industrial revolution, it changed the cookbooks, the kitchen, and the diet. Urbanization, with shift from rural to urban economies, mass production was needed for higher output at lower costs. And in orange there, this was the beginning of the use of additives, preservatives, and canning of foods. Expectedly, this brought about an epidemiologic transition with rising non-communicable diseases. So something had changed in between. Then there was globalization. I use this slide often. And its consequences, bad air days, how Asia got fat, we made it to the headlines. IBD came to our part of the world. And you see this paper that we wrote, about 10,000 patients, 15 countries, and emerging IBD in our part of the world. The question is, why? So if we have to learn the emerging perspectives, we should learn this. So if susceptibility of IBD, if there is 4 important parts, you can see the food, microbiome, exposome are all interlinked. And I think this has the impact of development of IBD as well as modification of ongoing IBD. So discussing dietary perspectives, there is 3 important parts. One is, what do we know? Second, what are the emerging perspectives? And the third, what is the real world scenario and what should we do about it? So what do we know? We know that exposome factors influencing the occurrence and outcomes of IBD, but just look at the green ticks. All these are related to food. High fiber diet, high omega-3 fat consumption, all associated with better disease outcomes, and similarly vitamin D deficiency, low fiber diets, non-nutritive additives, all associated with increased or complications of the disease. So if you see this and you try to understand, you will see animal protein high risk, linoleic acid high risk, but high dietary zinc, high fish intake, all are better. So in principle, it is the westernized diet habit that is associated with IBD increase. And I call it the standard American diet or the SAD diet, because I think that has high animal protein, less of fruits and vegetables. So these are all the early indications. Of course, processed foods are the culprit because it makes our food look very interesting. But this is that famous paper which shows that, just look at mayonnaise with the emulsifier and mayonnaise without the emulsifier, how much difference there is. Urbanized diet, effects on the gut microbiota. If you see again emulsifiers, artificial sweeteners, these have been implicated for the development of IBD. Now the next is that has there been any work to show that we can prevent IBD if we change these lifestyle factors? And if you see over here, when modifiable risk scores were based on established risk factors, you see a large number of dietary factors which, lower the risk. So if you see daily servings of fruit and vegetables, the highest quintile is associated with the lowest risk of IBD. Red meat intake, the highest quintile is associated with increased risk. And if we take less amount, then the risk of IBD development is lower. In fact, in this paper, they've shown these 3 large prospective cohorts plus 3 European cohorts, when all the analysis, and I'm not getting into the details of the statistics, but adherence to low risk factors could have prevented at least 50% of the development of Crohn's disease and adherence to a healthy lifestyle could have prevented even higher. So this is how, with large-scale studies now, we realize the importance of having diet. And then we come to this Faroese IBD study, and this is a very interesting story. Echo Epicom found highest incidence of IBD in the world in the Faroe Islands, 83 per 100,000 person years, versus Denmark, which is just nearby, 24 per 100,000. So now, why did this happen? What is there in the Faroe Islands? And they found that in the Faroese cuisine and prep styles, which has existed for centuries, they have something called reist, which is fermented in Faroese way. It's a traditional way for preparing meat, particularly mutton, and they studied and they found that this was grossly different between the Faroe Islands and Denmark, which, as I said, geographically are on the same latitude and just very nearby. Not only this, there were further studies, and this showed the excess ulcerative colitis risk in Faroese immigrants disappeared over time. So when these people who migrated and stayed back in Denmark, first generation, second generation, the risk of IBD came back to normal. So these are modifiable and preventable, and that is what we need to know. It's not like just like there is something in diet and okay, avoid this, empirical. There's now emerging evidence on the same. So what are the emerging perspectives? And you see this Lancet Regional Health Western Pacific, dietary and other lifestyle factors and their influence on non-communicable diseases in the Western Pacific region. Ultra-processed foods and human health. From epidemiological evidence, now there are mechanistic insights as to how that is happening. And if you see, this is just to highlight how much of ultra-processed foods we are taking. In one standard diet, in the sad American diet that I just mentioned about, almost more than 57% is actually ultra-processed foods. So that is what we are going towards. With time, that is where we are leading to. And how does it work? I don't want to spend too much time on this. The ability of gut microbiota to extract calories induces metabolic dysregulation. There's chronic low-grade inflammation, alteration in microbiota, increase of lipopolysaccharides. So now these mechanistic signals are becoming clear. Lipopolysaccharides infiltrate tissues, both liver and adipose, and trigger inflammation-related processes associated with metabolic pathologies, including obesity, insulin resistance, and IBD, of course. This is a paper which has just come in online, I think last week. This is about 1,24,000 participants from 21 countries followed across 20 years. Dietary intake was assessed. Primary outcome was the development of IBD, and people who were taking more than 19 grams per day of ultra-processed food had higher incidence of IBD. Fresh bread and rice consumption, lower IBD risk, and greater than 5 servings per day, higher risk of IBD. This is one of the most comprehensive, the pure study, which has just come out and has shown that. So a simple conclusion here, higher intake of ultra-processed foods, more risk of developing IBD. A healthy eating pattern should minimize consumption of ultra-processed grains. And then we come to what is another emerging area, that is the Mediterranean diet in IBD. Most clinical evidence supports this diet as an approach for IBD prevention and management. And I just wanted to mark that, it allows a little bit of wine and alcohol once in a while. So it's not all that bad, the Mediterranean diet, not always a torture. The Mediterranean diet, therefore, has made it to the guidelines. Dietary recommendations for IBD prevention are limited, but ESPEN recommends a diet rich in fruits, vegetables. ESPEN has added a recommendation to reduce ultra-processed food intake in the prevention section. So now it is making it to the headlines, not only treating IBD, but also more focus, and the emerging perspective is how to prevent IBD. The microbiome, of course, plays a central role. Westernization alters all these environmental factors that influences the microbiome and incites IBD in genetically susceptible individuals. At our lab, and I call it our Eureka lab because every day we find something, some results which are interesting. This is such an enigmatic area. And what we have found is there is a distinct microbial profile in treatment-naive Crohn's disease compared to healthy controls. The green is on one side, the red is on the other side. You can see that there is a distinct difference between the two groups. And then we thought, what about our people? We cannot change our diets to Mediterranean. So we found a lot of similarities between Indian and Mediterranean food. And you can see the tomato egg masala that we enjoy is actually the shakshuka there. And similarly, you know, the chapatis and whole wheat pita are easy to guess. The whole moong dal pakoras that I think at tea time we'll have today, and the falafel there. So what we did was we designed an IBD gut-friendly diet. We researched more than 400 recipes to modify the Indian cuisine using Mediterranean principles. And our first step was test it on our doctors. So what we did, we switched. We had a chef brought into our hospital, and he with his team were preparing all the meals in the hospital. Every day in the morning in the WhatsApp group, this was going as to what was being provided. And if you see over here, veg oats dosa, that was the difference. The fruit in the afternoon, and then at the lunch, multigrain fulkas, and things like that we did. When we did it, it was fun. We were all eating together, enjoying, and that was a lot of fun. But when we checked the gut microbiome before and after, we found increase in microbial diversity, significant increase in butyrate producers, increase in mucin regulators, probiotics, and we found red meat, sweets, and snacks negatively impact the gut. You can see cholesterol had come down, folic acid had improved, LDL has gone better, and most importantly for the doctors, majority of them actually more than 50% lost more than 2 kilos of weight. Accordingly, we've just released this book during our conference a few months back, Nourish to Flourish. This has a lot of recipes. Don't tell a child that you have to have that modulin every day that is good for your small bowel Crohn's disease. Add a little flavor to it. Make a little icicle or popsicle out of it, give it to your patient. That patient will always remember the doctor. Such is the importance of diet. So nowadays, the emerging perspective is a patient is a partner in the treatment. Give tasty alternatives. Just don't stop and say, you can't have this, you can't have that. Suggest almond milk, suggest soy milk, whatever suits, rather than do that. So the future, your food is going to be your best medicine, and the way forward is what we need to focus on. I'll spend just a minute on this. In the real world scenario, in each of our homes, traditional diets are being replaced. There is a decline in breastfeeding which began with the advent of infant formula, and that continues. There is an end of regional food isolation. There's no difference with the McDonald's across the globe. There are 40,000 McDonald's restaurants in over 100 countries worldwide. The busiest in Pushkin Square has had more than 250 million customers till date. That is the impact. Cook at home, we have forgotten. It's a life of escalators, elevators, and this was at one of the airports in Berlin. If you see, there is just one person walking up the stairs, and maybe he would have read this, burn calories, not electricity. Our microbiome has changed. This is Alex Kostick, whom I follow. Microbial DNA found in indigenous human paleofacies from unusually dry caves in Mexico 40% of ancient species are not even present today. This is what we have done to our gut, our micro environment. And we can tackle this. We need small steps forward. This is what the India government, and now it has come in advisory to tell about oil and sugar. This is from Karnataka, drop artificial color. What do we need to do to stop and reverse this change? Eat well, sleep well, exercise, and be happy. Food is a good medicine. There should be legislation. Colombia has introduced a junk food tax. There should be research. Preventive trials are the need for us to take things forward. And I'll end over here because I think So live well, eat well, and then prevent IBD. Food is an emerging area. It's going to be a pillar because it's affordable, and across the globe we can not only control the disease but prevent this non-communicable disease from increasing. This is my team here, and thank you once again.
Thank you. Two quick questions. Should we take the questions at the end?
Question after the session.
Sure, sure. Please join us on the dais, ma'am, then.
Thank you for such an enlightening talk, ma'am. For next talk, I would like to invite Dr. Vineet Ahuja.
Good afternoon, everyone, and I'd like to thank Dr. Anuroda for this wonderful invitation. As we have seen the meeting grow from India and India Habitat Center to out here. And also thank you for coming up with some very catchy titles like Tsunami of New Molecules and all. Although I thought it was a monsoon season, the moment I saw it, I was more reminded of the floods and the monsoons which are out here. And there is no doubt that we have, the rivers are flooded. But at the same time, when we talk about IBD, we may have a tsunami of molecules, but actually inflammation in a refractory IBD case or a tough IBD case is like a river in spate. It can cause huge amount of destruction. It is like the lumen out there, and you have the epithelial barrier on the sides, and there's a breach of epithelial barrier. There is huge amount of damage which a river in furry can do, and that is what IBD is. We have been providing boats to our patients in terms of corticosteroids, azathioprine, and subsequently I would say that the boats have increased in number and also increased in terms of the frequency with which they are coming, and now we have enormous number of boats which are coming. And so I thought that since Dr. Arora told me to talk about judicious approach in Tsunami, let me talk about a new boat which has arrived, and whether I would like to talk about it so that we educate ourselves about the new boat and we use it very judiciously in clinical practice. And this new boat is upadacitinib, that is a pan-JAK inhibitor or an oral small molecule. JAK inhibitors have an amazing way by which they act. We have been talking about TNF inhibitors, we have been talking about IL-12 inhibitors, we have been talking about IL-23 inhibitors, they are single cytokine inhibitors. But over all these cytokines, they are going to go and attach themselves to a neutrophil, they're going to get attached to a lymphocyte, and when they get attached out there, they're going to activate a JAK-STAT pathway, whereas Janus kinase pathway is activated, which goes and which gets phosphorylated, thereby it activates the STAT pathway, goes inside the nucleus, and there it leads to transcription of inflammatory factors. So if you have an inhibitor of JAK-STAT pathway, as a result, this cascade is simply stopped, and you stop not one cytokine but multiple cytokines out here. So that is the beauty of this action. In fact, it reminds you of a steroid. So it is like JAK inhibitors are the next generation steroid. So we have had tofacitinib already available. We have been using it for 3-4 years now, more than that. And so how is this molecule upadacitinib different from tofacitinib? Tofacitinib also does the same thing. Whenever cytokines are released, they get attached to JAK receptors, and tofacitinib blocks that. Tofacitinib is a pan-JAK inhibitor. It blocks JAK1, JAK2, JAK3, type 2. Whereas upadacitinib is a selective inhibitor. It's a selective JAK1 inhibitor. So what does it tell us? Whether it is good or bad? So why are we so happy with upadacitinib if it is only a selective JAK1 inhibitor? It should be inferior to tofacitinib. How does it strengthen us? Does it really help us? Well, the answer to that is simply one line from this editorial from Gastroenterology in 21, which says that probably we have hit the jackpot when we talk about upadacitinib. Tofacitinib has been useful only in ulcerative colitis. It has not been found to be useful in Crohn's disease, whereas upadacitinib is useful in both Crohn's disease and ulcerative colitis, and that is the gap which it fulfills. It is advantageous compared to biologics, how like oral administration, rapid absorption over 3 to 11 hours, excellent bioavailability, steady state reached in just 4 days. It is not affected by low serum albumin levels. When you give biologics, infliximab, adalimumab, if serum albumin levels are low, they will not act so well. Upadacitinib is not affected by that. There is no antibody formation with upadacitinib. There is an advantage compared to tofacitinib. It's a selective JAK1 inhibitor, so possibly higher efficacy. It does not block JAK2, so that is probably the reason that probably it may have lesser side effects, although that remains to be proven. So the question is, how are you going to place it when you are going to manage your patients with IBD? Which advanced therapy to use? So advanced therapy, as you all know, is biologics or oral small molecules. Because you have oral small molecules as well as injections, CATT is combined advanced targeted therapy. So when are you positioning the advanced therapy? It depends upon 3 things: clinical situation, efficacy, safety, cost. So when we talk about ulcerative colitis, let's say, the rule of thumb is that if there is a high disease burden, you would like to use infliximab or JAK inhibitor. We only had tofa till now we have upa also. If it is a low disease burden, then you may use vedolizumab and ustekinumab. When it comes to safety, vedolizumab and ustekinumab are very safe and can be used. When it comes to cost, then till now we had only one agent, that was tofacitinib, or you could use biosimilars, which are again expensive compared to tofacitinib. Here again, upa fits in the sense of that it is again not a very high cost medicine. Talking about Crohn's disease, there's a slight change. Low disease burden, you can use infliximab as well as adalimumab. Adalimumab, which we thought is not so useful in ulcerative colitis, proves to be quite useful in Crohn's disease. Tofacitinib not useful in Crohn's disease, upadacitinib definitely useful in Crohn's disease, and if you have a low disease burden, you may use ustekinumab or vedolizumab. Safety again, vedolizumab and ustekinumab, they fit in the bill, and when it comes to cost, we had no choice for our patients with Crohn's disease till now, and with the availability of upadacitinib, that is one big gap which has been plugged. So the question is how to use upadacitinib. The dose is 45 milligram induction for 8 weeks, and thereafter you can drop down to 30 milligram or even 15 milligram for the maintenance phase. For Crohn's disease, you would use 45 milligram but for 12 weeks, not for 8 weeks, and thereafter you can drop down to 30 milligram or 15 milligram. Can be taken before or after meals. Grapefruit to be avoided. Induction period can be extended. There is no hard and fast rule that you have to induce only for 8 weeks and then you have to stop even if the patient has not fully responded. You can carry on. There is no dose change in mild to moderate renal impairment. However, if GFR is below 30, then you would like to decrease upadacitinib dose. If GFR is less than 15, you would not like to use it. If in the cirrhosis there has been a little bit of mixed literature, but in general, child A and B, the dose should be less. In child C, you would not like to use upadacitinib. Not to be given along with azathioprine or cyclosporin, not to be combined with anti-TNF inhibitors because the chances of infection would be very high. So before starting, what is the checklist? It is the same as for other biologics, viral markers, test for latent TB. If there is history of thromboembolism, unless really pushed against the wall, do not use it. And if you are going to use it, then start anticoagulants. Vaccinate with the herpes zoster vaccine. The recombinant vaccine is available. You can give the 2 doses. Lipid profile should be checked, and liver function test and kidney function test should be checked because it is metabolized by liver and kidney. Another interesting thing out here is that it is metabolized, as I told you, by liver, and the metabolism is by CYP3/4A. So there are interesting drug combinations out here which we tend to ignore. If a patient is on ketoconazole, it's a strong inhibitor. It will increase upadacitinib levels. Grapefruit, although more common in USA, but the cultivation has definitely increased in India, particularly in northeast areas. So another thing to be kept in mind that grapefruit would increase the upadacitinib levels and may cause a lot of side effect. Diltiazem, commonly used drug. Clarithromycin, commonly used drug. Amitriptyline, commonly used drug. They will all cause CYP inhibition, increase the UPA levels, increase the toxicity. INH can also do that. On the other hand, rifampicin is a CYP3 inducer and reduces UPA levels, and that is a point of what I would say confusion for us, because how to treat latent TB when you're putting a patient on tofacitinib or upadacitinib? Are you going to give INH? Are you going to give rifampicin? That's an interesting point. If a patient has renal failure, then this is a whole list, but just concentrating on TAFA and UPA, you will, as I told you, if a patient has severe renal failure, end-stage liver disease, you cannot use upadacitinib. When would you start upadacitinib? Are you going to again use it indiscriminately, or are you going to use it when it is really required? It has to be given whenever you're planning to start advanced therapy, in any case with ulcerative colitis or Crohn's disease. The way you do it, like steroid-dependent disease, steroid-refractory disease, azathioprine intolerant disease, or in cases with Crohn's disease where you're going to use top-down therapy, or if there is failure of first-line advanced therapy. It does not replace steroid as a first-line therapy in mild Crohn's disease or anywhere where you're not planning to start top-down therapy. Do you expect a better response? Do you think patients are going to do much better with upadacitinib? No. Actually, the responses remain the same for all advanced therapies, between 20 to 30% for remissions and around 50 to 60% for responses. They roughly remain the same. So it is not that the response is going to increase. It is just that you have another choice if you have had a failure of previous agent. When not to use it? Thromboembolism, I told you. Pregnancy, contraindicated. You have to stop 1 month before conception plan. Coronary artery disease, CVA, elderly with a high risk of infection, you would like to shy away from this drug. Remember that acne is a very common side effect. Around 30 to 40% of patients have acne with either tofacitinib high dose or upadacitinib. If you have put a patient on any of these drugs, the patient develops acne, you know that it is because of that. You have to check for neutrophil count. If it is less than 1,000, check for a liver function test because hepatotoxicity is seen with these agents and you have to stop it. Now, we have patients with acute severe ulcerative colitis. We have been using tofacitinib out here. The question is, can you use upadacitinib also in a patient who has acute severe ulcerative colitis? So, whereby you would like to induce remission or maintain remission. So, a recent study still in press which talks about a multi-center retrospective data which shows that in acute severe ulcerative colitis, if you use upadacitinib along with IV steroids, or if a patient has failed IV steroids, you use upadacitinib, it probably is as beneficial as in tofacitinib. So safely you can give it instead of tofacitinib. If a patient has extraintestinal manifestation, would you like to use upadacitinib or not? Well, upadacitinib has already been FDA approved for rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, non-radiographic axial spondyloarthropathy, atopic dermatitis. So if your IBD patient has any of these extraintestinal manifestations, again, UPA will be a great choice to use out here because it will take care of both the diseases. Like ulcerative colitis would have rheumatoid arthritis, atopic dermatitis, or axial spondyloarthropathies. Can it be used in perianal fistulizing disease? Infliximab is the first drug of choice out here. What if a patient has failed infliximab or patient cannot afford infliximab? Well, a recent study showed that yes, upadacitinib has been found to be beneficial in perianal fistulizing disease and safely can be the first line of therapy if the patient cannot afford infliximab. Now, if you put a patient on tofacitinib fails, then can you still use upadacitinib? They are the same class, JAK inhibitors. Would upadacitinib work? Very interesting study, J2J multi-center study, which shows that yes, upadacitinib, when it was used in 63, it was successful in 60% of patients, even when they had failed first JAK inhibitor, showing that if a patient has failed tofacitinib therapy, don't be hesitant in starting upadacitinib for that patient. There is a good 50% chance, 60% chance that the drug would still work. If a patient is on upadacitinib 30 milligram and relapses, would you like to change the drug? Well, don't change the drug. Here, antibodies are not formed. You can simply go and reinduce. You can again start 45 milligrams, reinduce one, and this recent study highlights 2-3 very good messages. One is that you can restart 45 milligrams of upadacitinib again. Second, induction period may not be sacrosanct of 8 weeks or 12 weeks. You can go on for 16 weeks, you can go on to 24 weeks. Just watch for the side effects out there. So finally, I'll just take you through 1 or 2 cases. There's a multifocal small bowel stricturing disease. There's a university professor went around lecturing a lot, but at the same time he was having profound anemia, HB of 8 gram with recurrent melena. So MR showed clearly multiple short segment bowel wall thickening of small intestine. Steroids were given. So the next step was addition of biologics. He was started on adalimumab. There was no response, HB kept on dropping. Thereafter shifted to stecunimab 8 weekly, there was no response. Thereafter shifted to stecunimab 4 weekly. So this is a biologic trail over 2 years, no response. Then vedolizumab was added so that now probably the patient would benefit. But however, there was no response, and subsequently it was decided, let's go for surgery. Even though 150 centimeter of small intestine was involved, he underwent surgery, and post-surgery, he's doing very well. We have put him on vedolizumab to prevent post-operative recurrence, and at the same time, but the patient is very happy, and he is back to his job, etc. Another case, 45-year-old lady who is symptomatic from 20 years, case of Crohn's disease, initially treated with steroids, then treated with azathioprine. He had multifocal short segment thickening. Gradually the disease was progressive, went on to biologics, infliximab given, was good with infliximab for good 2 years, loss of response. Adalimumab started, good with adalimumab for again some time, loss of response, went on to ustekinumab, some response, went on to 4-weekly ustekinumab, lost the response, what to do. But she could procure drug from outside upadacitinib, so we started on upadacitinib, and now she is doing very well. Again showing that how the algorithm is gradually progressive. Final case is, now I'll show you, so although it's a Crohn's disease talk, but I thought I'll show you this one case of ulcerative colitis. 37-year-old lady who developed ulcerative colitis in 2003 at that time. Initially very responsive to azathioprine, doing very well, screening, colonoscopy and all done, but by 21 she started having major relapses, possibly post-COVID, started on tofacitinib thereafter. She had some response, lost the response, and then you sequence, she went on to vedolizumab, lost response after 1 year, went on to ustekinumab, lost response after 1 year. Thereafter, we added ustekinumab and tofacitinib dual therapy and also gave her tacrolimus enema. Again, after some time, she started losing response. But in 22 and 25, around 3-4 months back, she procured upadacitinib from outside, and she is doing very well, and she says that she is doing well. So here's a patient who was on tofacitinib, but the response was captured with upadacitinib, again showing the kind of advanced therapy trail which our refractory patients undergo. So finally, I think I would just end my talk by paying my gratitude and respect to my teachers, my mentors who have been my role models, and I think no better day than a Teachers' Day to pay my respect to my teachers, to whom I remain indebted always. Thank you so much.
Thank you. I think we'll take the questions at the end of the session.
I would like to invite on stage our next speaker, Dr. A.S. Puri.
Is there a pointer? No pointer. Good afternoon, everybody. And at the outset, I'd like to thank the organizing committee. Special thanks to Dr. Anil Arora and his team, Praveen and Ashish. So, Dr. Vineet Ahuja just showed you that we have a Tsunami. I'm showing you, the multicolored pills. And the interesting thing is you can add a couple of vials also to that to complete the spectrum. And most of these drugs can actually be grouped into just 5 categories as far as IBD is concerned. And most of them have got specific side effects. So in the next 15 minutes, I'm just going to talk about the tips to prevent these adverse events. And my theme slide, it's not moving. So as I said, there are only 5 categories of drugs. And this is in chronology. The first came the aminosalicylates, then the steroids, immunomodulators, biologicals, and after listening to Vineet, we can add UPA as well to the smaller molecules available in India. And let me start with citalopram. Now, citalopram, I'm not sure how many of you would be currently using, probably a small minority, but this was the original drug that came. The problem with citalopram was that it was associated with so many side effects such as agranulocytosis, fever, hypersensitive pneumonitis, drug rash, interstitial nephritis. And then this is my theme slide because I'm going to show it whenever we have a problem, and this is probably got from the rivers that Vineet was showing. When there is a river flowing and there's an obstacle, then you find a way around it. The rivers did it, and then we also follow the same. So it was found out that the main adverse events are because of the sulfur moiety. So if you can remove that, then you will still have the drug. and you won't have the side effects. So that's how simple it was. And with the advent of the DHM technology, which is there with most companies now, this is the 5-ASA tablet which is available. It is enteric coated. Once it reaches the ileum and the pH is more than 7, then the outer dissolves, and this is the hydrophilic matrix, and that's how. So we've managed to circumvent all the side effects of salzopyrin with just increasing technology. So kudos to the pharmaceuticals. The next drug I'm going to talk about is steroids. And before I talk about steroids, the preamble is, when you start steroids, it's the same, don't start a fight. But if you have to, then you hit first and you hit hard. So hit first means that steroids are always, whether it's ulcerative colitis or it's Crohn's disease, they are for induction. Hit first. Hit hard means that you start with the highest dose. You can't say, oh, I think you have a mild flare, I'm going to give you 20 milligram of. You better go on to some other drug, because that's not the way you deal with steroids. So this is the impact that steroids had. No other drug in the history of IBD has had such an impact. And this is the pre-1950s. You can see the mortality was about 22% for 1 year with acute severe ulcerative colitis. And with this paper from Britain, from True Love Wits, it came down from 22% to 8%. And in the next 60 years, probably just a shade less than 5. So that's the progress we made. Look at the slope of this, and this is at best just a gentle slope. So that's the impact that steroids have had in the treatment of IBD. So is steroid toxicity preventable? The answer is yes, definitely yes, provided you follow the 4 rules. So what are the 4 rules? The first, be sure of the indication. Because there's an overlap of Crohn's disease with tuberculosis in India, if you end up treating tuberculosis thinking it is Crohn's disease with steroids, then that's not where it's indicated. So be sure of the indication. Second, as I said, the dosing. The dosing is important. You have to start, for an adult dose, it's 40 milligram. In exceptional cases, maybe 60, but that's the dose that you start with. The third important point is the duration of therapy. The duration of therapy, as I said, hit first, so it is used as induction. So for induction in ulcerative colitis, even in Crohn's disease, 8 weeks, you stretch it a little more, make it 12 weeks, but we're not going to make it in. Steroids are not used for maintenance therapy. That's the bottom line. And last, anticipate the adverse events. So these are the 4 rules of steroid usage. I could talk about all of them, but in GI I've just picked up 2. For young women to have cosmetic disfigurement, both these young ladies were given steroids as maintenance therapy. So you can see that they've all become Cushingoid, they have hirsutism, and that for young women is totally unacceptable. This is cosmetic. We have more serious things in India, and this is a young lady. She again, ulcerative colitis, treated with steroids for a long time, and this was the chest x-ray. She had not only a pleural effusion, she also ended up with TBM, or tuberculous meningitis, and we lost her. So be very careful about the rules of steroid usage. Next, I'm going to talk about thiopurines. They are one of the most commonly used drugs in IBD. In my next slide, I'll show you how much of it we are using. It's a bit outdated. As opposed to corticosteroids, this is for maintenance. We do not use thiopurines for induction of remission. The 3 major drugs that we are having as of now is azathioprine, 6-MP, and methotrexate. And they're associated with 2 major side effects, which is bone marrow suppression and pancreatitis. Very, very, very rare. I don't think we've ever seen a hepatosplenic T-cell lymphoma. This is just to highlight how much of immunomodulators we're using. I'm sorry, but this is a very old slide, almost 15 years old, or 13 years old, but we haven't updated this data ever since, so I have to use that. And 13 years ago, about 30% of the patients of ulcerative colitis were on immunomodulators, and 2/3 of the patients of Crohn's disease. They are associated with several side effects, but which is the one which warrants discontinuation? Standing apart, leukopenia, followed by hepatotoxicity, pancreatitis, and GI intolerance, which is common in these patients. So here I am answering the question, in the bone marrow, which is the cell line of the 3 cell line, which is the most vulnerable to Azoran? And that is undoubtedly the leukocytes, followed by the red cells, and the platelets seem to be getting much less of the impact. So the question then is thiopurine toxicity preventable? The answer is yes and no, because pancreatitis is more like a hypersensitivity reaction to sulfur or to penicillins, cannot be predicted, but the hematological certainly can. And we have at least TPMT testing both in India, we have genotype, and in some places they're also doing the enzyme activity. NUDT is the new kid on the block, but most important is you monitor their hematological profile every month at least for the first 3 months, because that's where most of the severe cases occur. My next slide, I'm going to be talking about this. So you can do the TPMT genotyping or enzymatic activity. Genotyping, much less, the incidence is much less in India, probably less than 1%. So it's probably not cost effective to do genotyping in India. Enzyme activity, what it tells you is that how much of the drug is being metabolized from 6-MP to 6-MEMP by the shunt, and if the shunt is very high, then you best avoid it because most of it is going to get shunted. The AGA recommendations are that if you are starting patients on thiopurines, then they recommend TPMT testing, but as they mentioned very clearly, it's a conditional, the strength is conditional, and low quality evidence. What is probably more important in the East is NUDT, because this is an enzyme which is associated with metabolism of 6-TGN. The enzyme causes thiopurine-induced leukopenia, more common in the Far East, but also in the southern part of the country. And in those patients who have a double whammy, that is mutations in NUDT as well as TPMT, they are the worst hit. Just to give you a broad, what does NUDT do? So NUDT is basically like for the metabolites of immuran, it's like a sewage plant. So you have what is the sewage plant? The sewage plant is all the toxic waste coming in, and it converts it into even clean water, so as to say. So similarly, the NUDT converts the toxic 6-thio-GTP. So this is a triple phosphate. So all it does is take off 2 phosphates, converts it into a monophosphate, and that reduces the toxicity. So just imagine, just one small enzyme, that's all the function that it has, but what havoc it causes. Indian data, slightly old, almost 7 years old, but of the 200 odd patients, genotyping done by RFLP, and the variants were found in almost 20%. And then 100 patients followed up. 10 of them developed toxicity, and all 10 had mutations in the NUDT. And when this happens, this is young patient, he had pancytopenia, so you can see this is the petechial rash. And when this kind of a thing happens, you wish you were never born. Very difficult to handle. This is the bone marrow smear, and there's hardly any myeloid series that you can see. And if you do a bone marrow in these patients, then it starts looking like a liver biopsy. In a liver biopsy, we have septal fibrosis, and we have in a fatty liver, and there's all fat. And the pink is all bone trabeculae, and there's nothing left except fat. So this is exactly what is one of my patients who had Azoran-induced pancytopenia. All that you can see in the marrow is a scattered megakaryocytes, a few lymphoid cells, but the myeloid series are just disappeared completely. And this is another patient that I saw. She was an air hostess, and she had IBD. She was given a combination of Imuran and infliximab, and she ended up with pancytopenia. She had homozygous mutation in NUDT, which was not earlier checked for. And not only did she end up in an ICU for 2 weeks, luckily she came out. She was an air hostess and she lost her job because of the disfigurement that occurred. Lastly, just before that, I'm going to talk about the usage pattern of biologicals. We go back to the same slide. And again, I apologize because nobody's updated this data. So about 13 years ago, we had 1%, less than 1% and 2% for Crohn's disease and for ulcerative colitis. It's a lot more today, that is for sure, but we don't have the data. And as we know that infliximab is a double-edged sword, certainly helps out fighting the IBD, but it comes at a cost. And because of it is TNF alpha, and in those patients who have latent tuberculosis, where the bacilli, the TB bacilli are walled off in the granulomas, the anti-TNF kind of, for them it's like a jailbreak. They're all let loose. And the original report by Bob Keane in NEJM, 130 cases from Europe from multiple centers, and he was the first one to show that 27% have disseminated disease. In India, at least 2 or 3 studies. This was the first from a multicentric study from India, from Ludhiana, Delhi and Mumbai, and we showed that in patients of ulcerative colitis, approximately 8% of our patients will develop tuberculosis. And this is again just to show you what is the kind of tuberculosis. In India, we always have reactivation. It's not reinfection, and this is the classical tree in bud appearance. The tree is from the pulmonary artery. The bud that you can see is from the airways. The airways have got plugged with the mucus, etc. So classical appearance of tree in bud. I'm not sure whether the English is correct, whether it should be tree in bud or tree and bud, but we leave it for that. What is the risk of TB with biologicals? The maximum risk is with Remicade and with the adalimumab, and much lower, probably negligible with Vido and with Osteki. These 2 molecules are set to hit the Indian market. We don't have the Indian data as yet, and therefore the query. So how do you reduce the risk of reactivation of tuberculosis? The first 3 were well known, chest X-ray, Mantu, and the Quanti Gold. And then we have data coming from Dr. Vineet's group from AIMS that if you add HRCT to this, replace the chest X-ray with the HRCT, then the risk really becomes minimized. In addition, if you have latent tuberculosis, you cover them with these 2 drugs for at least 3 months. And what is required is close monitoring in the first 6 months. And the warning signs, if the patient starts developing fever, always look for tuberculosis reactivations. What are the contraindications? The contraindications, in addition to sepsis, is active TB, severe heart failure. This is specific for anti-TNF drugs. And I know some of you would know that original infliximab was thought to be a treatment for congestive cardiac failure for patients with multiple sclerosis, and a relative contraindication would be advanced age. Lastly, the small molecules. Vineet has already told you about the new introduction in the Indian market of Opada. We don't have ozanimod. And these drugs, at least the JAK inhibitors, are associated. The most dreaded complications is the MACE. And in fact, it was exactly in September 2021 when the black box warning came. But that was in patients of rheumatoid arthritis treated with TOFA, aged more than 50 years, who had significant underlying cardiovascular disease, and therefore the higher risk of venothromboembolism, not very relevant in IBD because possibly our patients are much younger. What we do see is zoster, and this is early lesions in T10 dermatome. This is the late lesions, the vesicles that you can see. And the mimic is acne because this is the forehead is supplied by the cranial nerves. It's not supplied by the somatic nerves, so it doesn't follow any dermatome. So this is not acne. This is not zoster. This is acne. And how do we prevent it? Simple. We go back to the same slide, and we show that if you have the availability of the vaccine, then you can definitely prevent it. 2 doses. The issue is the cost, which is approximately 10,000. Because of shortage of the time, I'm not going to go any further, and I'll stop here, and thank you very much for your patient listening.
Thank you, Dr. Puri.
I would like to invite our next speaker, Dr. Naresh Bansal, onto the stage.
Good afternoon, and before I start, I would convey my regards to all teachers sitting here on Teachers' Day. In the next 10 minutes, I would take you to a journey of IL-23 inhibitors, which are important drugs in management of inflammatory bowel disease. My topic is, are all IL-23 blockers are same? So first of all, what is IL-23? IL stands for interleukin. The name is because they have capacity to interact from one cell to other cell. That is why they have name of interleukin. They were thought to be secreted from leukocytes, and therefore the name was interleukin. There are a lot of interleukins, and interleukin 23 is an important mediator which drives inflammation in lot of inflammatory conditions like psoriatic arthritis, plaque psoriasis, and inflammatory bowel disease. It was discovered in 2000, and next two statements are very important, that it is a heterodimer. It has got two subunits, P19 and P40, and P40 is also shared with interleukin 12. And this has importance in next slide. So what are the all IL-23 inhibitors available in the market? Not in Indian market, worldwide. First generation is ustekinumab. Ustekinumab is not pure IL-23 inhibitors because this inhibits the P40 subunit as I just mentioned, and therefore as P40 subunit is shared by interleukin 12 as well as 23, it blocks both. Next four are pure IL-23 inhibitors, mirikizumab, guselkumab, risankizumab, and brazikumab. In Indian market, we have only one, ustekinumab. So this is the current FDA status of all IL-23 blockers. Usteki was the first to be approved in 2016 in Crohn's disease, and subsequently all have been approved in Crohn's as well as in ulcerative colitis. Latest addition are mirikizumab and guselkumab. This is how IL-23 acts in inflammatory bowel disease. As we know that IL-23 has two subunits, P40 and P23, P40 and P19, and P40 is actually shared with IL-12 also. So Usteki blocks P40 and therefore blocks both IL-12 and 23, while risankizumab, guselkumab, brazikumab, and mirikizumab, they blocks P19 and therefore they are pure IL-23 inhibitors. Out of these, bracizumab has been is not in the market, and AstraZeneca was developing this molecule, and they stopped this molecule because they were developing another molecule, risankizumab. So this activation of these IL-12 receptors, phosphorylation of IL-12 receptors ultimately lead to the activation of JAK state pathway, and state 3 is important in IL-23, but state 4 is important for IL-12 pathway. That again differentiates them. So there are various cells, immune cells like dendritic cells, macrophages, they secrete IL-23 in response to various immune stimuli through the toll-like receptors. And when these cells secrete IL-23, they actually perpetuates the proliferation of Th17 or CD4 helper cells, which ultimately leads to the release of IL-17 and IL-22. And these inflammatory mediators ultimately disrupts the barrier integrity and leads to inflammation. That is how these IL-23 are important in the cascade of inflammation. So again, through these stimuli, through the toll-like receptors, macrophages, dendritic cells, neutrophils, they all secrete IL-23, subsequently leading to the phosphorylation of IL-23 receptors, leading to the JAK state pathway activation and transcription of lot of inflammatory mediators in the nucleus. So if we talk of these individual biologicals, ustekinumab was the first and most studied drug which targets P43, which targets P40 shed by IL-12 and 23, approved for both CD and UC, and efficacy in CD was established by Unity trial. Clinical response at week 6 was 34 to 56% as compared to the placebo, which was 21 to 29%, maintenance 50%, and efficacy in UC was established again with Unity trial. Rishankizumab has also been approved in both. Efficacy in CD was established with advanced or motility trial. 42% clinical response at week 12, endoscopic remission at week 44, 39% as compared to the placebo, 13%, and similarly efficacy in UC was established with INSPIRE and COMMAND trial. Mirikizumab has also been approved in both ulcerative colitis and Crohn's disease, and various studies have shown the response rate around 30%. So this is a summary of efficacy of different IL-23 inhibitors in Crohn's disease. Guselkumab, Galaxy study, Brazikumab, Mirikizumab, Rishankizumab, and we can see that all have IV induction, and subsequently they have to be given subcutaneously for maintenance, apart from Guselkumab, where you can induce remission with subcutaneous also. There is another difference between these IL-23 inhibitors, that if you want subcutaneous preparation throughout the induction and maintenance, then we can use Guselkumab, and we can see that the primary endpoints are also different. Clinical response rate is also different amongst the different molecules, and that is although the population studies is also different, so we cannot compare them directly, but we can see their response rate is different. Now there are no head-to-head trials between all IL-23 inhibitors, but Rishankizumab has been studied against ustekinumab, which is one pure IL-23 inhibitor, and another is usteki, which is not pure IL-23 inhibitor, so it inhibits IL-12 also. And this study which has shown that Rishanki is superior than usteki in terms of endoscopic remission. And there is another study which compares Guselkumab versus Golimumab versus combination. This study shows that Guselkumab and Golimumab both are equal in efficacy, but the combination is better. So why are all IL-23 inhibitors different? Because these monoclonal antibodies are different IgG classes. Rishanki is IgG1, Miriki is IgG4, and Guselkumab is IgG1 delta. And therefore, they have different binding epitopes over the receptors. They differ in pharmacodynamics as well as in pharmacokinetics. Their metabolism is different, their T half-life is different, their elimination rate is different, their tissue distribution is different. Usteki is non-selective, and therefore it inhibits both P40 and P19 subunits, inhibit IL-12 also. Selective IL-19 inhibitors differ in even selective IL-23 inhibitors if we take and we leave aside usteki, then they also differ in IL-23 receptor binding affinity as well as potency, and they differ in immunogenicity, because just if we see the name, some of them are Mumab, some of them are Numab, some of them are Qumab. So their source and immunogenicity potential is also different. Some of them are humanized, some of them are recombinant. And their pharmacokinetics is also different, their tissue distribution, metabolism, elimination, all are different. And these things make them different even though they belong from the same group. So as I mentioned that efficacy comparison have been studied in Crohn's disease, usteki versus selective IL-23 inhibitor in sequence trial, and in sequence trial was between usteki versus Rishanki in Crohn's disease, and here they found that Rishanki was superior in endoscopic remission as compared to usteki at week 54. Another comparative study was between Guselkumab versus ustekinumab versus placebo. Again, the Guselkumab was superior as compared to the usteki. We must remember there are no direct head-to-head trials between different IL-23 inhibitors. There is no, and network meta-analysis has found that their efficacy is similar almost. But the studied population is different, and we are not expecting any head-to-head trial in next 2 or 3 years, because yet there is no registered trial on the clinical trial site. So if they are different, can we use one IL-23 inhibitor in IL-23 inhibitor exposed patient? That is the question. And the answer, this is the study just of 10 patients published from Japan this year only. And they have given mirikizumab in Crohn's disease patients, in sticky exposed patients, and they found that mirikizumab was effective in 7 patients out of 10. If we talk of safety profile, just 2 minutes. If we talk of safety profile, they have low rate of adverse events, and the safety profile is generally similar among all IL-23 inhibitors. Infection risks are high, as just like any immunosuppressants. LFT monitoring is required. Sticky has the maximum real-world data. Reactivation of TB. Just you have listened that patient can die from meningeal tuberculosis if there is reactivation of tuberculosis. And this is very, very important in Indian population, where reactivation of tuberculosis is of paramount importance when we use TNF blockers. So reactivation of tuberculosis is minimal with Usteki, and it is further minimized with pure IL-23 inhibitors because they don't have effect on interferon gamma, no disruption of granuloma formation. So to summarize, all IL-23 inhibitors are not equal. Selective IL-23 inhibitors are better than IL-23, IL-12 inhibitor. They differ in pharmacokinetics and pharmacodynamics. They differ in efficacy and immunogenicity. Head-to-head trials are needed for their proper positioning and management of algorithm. Precision therapy requires identification of key predicting factors and biomarkers. Like there are some studies on IL-17 and IL-22 which can predict whether these molecules will be effective or not. The good part is oral IL-23 inhibitors are in pipeline, and few gut-specific oral IL-23 inhibitors are also in pipeline. So that is the ray of hope. So they are similar but not identical. Thank you.
Thank you, Dr. Mansal. I think we'll have time for a couple of questions, 2 or 3 questions. All the speakers are in the front row, so we're passing on the mic to them. I'll probably ask the first question, take the privilege of that. So from Dr. Rupa, that we have a lot of labs now doing this targeted microbiome analysis for patients and targeted therapy in terms of the type of probiotics to be used or prebiotics to be used. Any role for doing this sort of analysis in the general population or IBS patients or IBD patients for that matter?
I think we are doing it, but I think we are still not in a stage to recommend a particular thing. But we have seen some patients with very low probiotics, maybe we can. And there are some patients who are taking a lot of probiotics, we find dysbiosis in their microbiome. What we are doing right now is dietary modifications based on the gut microbiome. I think this is an evolving field, and but it's too early to say. We will have a microbiome pill one day that you are less on this, so you just take this.
I think I liked your take-home message that the traditional Indian diet, unprocessed, fresh, actually is the best microbiome regenerator in the body.
Yeah. Yes. I think first of all we should be thankful on Teachers' Day. I think you should be thankful, all of us, to the organizers for giving us the best 4 teachers for IBD on Teachers' Day. I don't think anywhere in the world we could have had better talks on IBD than we have today. I think a round of applause for all of us. My first question is to Dr. Rupa. What is the contribution of the diet to development of IBD in a conundrum of genetics, microbiome, stress? How much does the diet alone contribute?
I think lifestyle and diet, I would combine the two, and it's a very significant thing. And if you see Asia, we never had IBD here. I mean, 30 years ago, 2 decades ago, IBD was a rare diagnosis. Now we have IBD meetings and everybody is seeing IBD.
I think with Trump's tariffs coming in now, we should switch back and stop all McDonald's. And
I completely agree. And I think Indians traveling, not only the migrant population gave us the first inclination. Dr. Jayanti's work from UK told us that Indians traveling outside. So we maybe have it in our genes, in our part of it world, but our environment was protecting it. Now it's percolating. We are finding in rural India, we are finding across high-end migrants. So I suppose diet and environment and lifestyle together, yes.
A simple question to Dr. Vineet after his excellent talk. I think we started with the topic of tsunami, as the tsunami which we have had of rains in Delhi over the last 5 days. Luckily we have a good sunshine. do you think there is an end of tsunami to biological? Can we just, as a simple practicing gastroenterologist, to shift over to single molecule to upadacitinib, which is an all-weather friend now?
No, but again, upadacitinib would be effective in 30-40% of cases. So none of them is going to be 80, 90, 100% effective. So you are ultimately going on to sequence, have one, continue it for 1 year, then it will lose effect, move on to the next. So all you're doing is controlling inflammation, and you have different agents to control inflammation. You do not have a cure as yet.
My question is after steroid refractory or steroid
so
dependent,
you can start
there can be one molecule?
So you can start upadacitinib, but again it will be effective in 40 to 60% of people, and that too for a duration of time. So you will have to sequencing. It is not the only answer. It is just that for Crohn's disease we did not have a cheap molecule compared to biologic. So there we didn't know what to do with the patients out there. They had to be marinated in steroids. There you have a choice now, like you had for tofa and ulcerative colitis.
A couple of questions, ma'am. It goes without saying that SAD diet or what you said, standard American diet is bad, processed food is bad. But if we remove all that, but among Indian diets, like we have Kashmiri, we have South Indian, Bengali, has there been any difference in IBD? That is one question. Second, the practical points which our patients ask, masala le sakte hain nahi, or doodh le sakte hain nahi, I mean milk, and there are certain other things, wheat, rice, what is good? So both these questions.
I think this is a very relevant question, and I'm from Bengal, staying in Hyderabad, so I really cannot take sides there. But I think traditional diets and home-cooked diets are things that automatically reduces a lot of these ultra-processed things. There was, a few years ago, it was emulsifiers, and more than the masala or what you say. And now we feel all the packaged ultra-processed things. So I think you cannot tell the patient, and that was the purpose of the book also, you cannot tell the patient lifelong go on something which you don't like. I mean, which is less tasty, which is bland, which does not have anything. I think you should tell your patient that cook at home, eat what you feel is tasty, and take what you think you like. We are still not in a position to really tell the patient. There are many patients who tolerate lactose well. If they don't, or during an acute flare, maybe you can restrict. I feel that after seeing so many patients, too restrictive a diet is never followed, and it's better to give them easy solutions. Now with the latest, this paper which is going to come, this 20-year study, it says that fresh rice is good for IBD patients. In fact, it prevents development also. And, grains and other things. So this paper is going to watch out for the pure study, which will give us more indications. I think that
and
is
spices and all.
Spices, I think you should not restrict all spices. They should not be irritants. Like, already there is the colon is angry and you're just throwing in a lot of spices, but enough to make the food tasty is what I would tell.
To Dr. Vineet, please.
Can I take the liberty of asking a question from Dr. Vineet? Hello, sir. Being a surgeon, I just wanted to know that there is a constellation of the drugs that you have, and we keep prescribing from one group to another, and then a relapse occurs, then you change the dosing. As a surgeon, I want to know which is your endpoint when you refer the patient to the surgeons.
So in the case where I showed, that was a case which had extensive involvement of small intestine. There we tried all things and then only sent to the surgeon and showed that surgery was the answer. In cases where there's very limited involvement, particularly if it is terminal ileal involvement in Crohn's disease, there upfront we do offer a case. For example, recently a case from Srinagar, young intern, and upfront we offered him surgery and he was very glad to take it, and after that he's done well. In ulcerative colitis, again, in acute severe ulcerative colitis, you want to offer them surgery, but again at the same time the choices are so many that everybody is tempted, including the physician and the patient, in terms of exercising those choices. So there also a surgeon we feel should be brought immediately into the loop. What do you feel, Dr. Puri? You would
For the surgeon also, I just want to make a point that surgery is not the end. The problem with Crohn's disease is the post-operative recurrence. So depending on whether you're looking at clinical recurrence or histological recurrence or endoscopic recurrence, the recurrence will come. I mean, all of us have seen patients who ultimately, after their surgery also, yes, they have a honeymoon period, maybe which can be very variable, 4 years, 5 years, but sure enough, and unless you monitor these patients very carefully, frequently, with calprotectin or CRP or other, you have to start them on biologicals anyway. Surgery is not the end. You will have to give.
So even once it becomes refractory.
I'd just like to say that we need you. We love those honeymoon periods that patients have because there's dramatic improvement from recurrent subacute intestinal obstruction. I would say that yes, you do that definitive thing, and after that we need to keep on monitoring and prevent a similar stricture from happening. So I think what Dr. Vineet was saying, that if there's a limited area involved in resection, we need you guys.
Thank you. Also to add, I think maintenance therapy has to be continued post-surgery in one form or the other to prevent the recurrence episodes. Also in ulcerative colitis, I think the need for surgery has gone down dramatically. On the other hand, in Crohn's disease, because whenever it presents with obstructive disease or limited terminal ileal disease, surgery still has a major role to play even early on in the disease process.
Dr. Vineet, last question. As TOFA is a pan-JAK inhibitor, while the other is only JAK1, so why it's not working in the Crohn's?
So there are 2 or 3 reasons for it which have been postulated. Number one is that in the trial on tofacitinib in Crohn's disease, people feel the dose used was less because with higher doses of toxicity is more. If they had used higher doses in that trial, probably they would have got that effect. Secondly, in that trial, the placebo response was also a little more. That could be. Other reason for that is that it's a JAK, it has a lot of affinity for JAK1. So JAK1 is the one where the major action takes place, whereas JAK2 is more associated with the side effects. So tofacitinib, the distribution would be for all the 4 receptors, JAK1, JAK2, JAK3, type 2. Whereas here it is the selectivity is mainly for JAK1, so most action would be on JAK1. So there will be more, emphasis on JAK1, which would cause the beneficial effect. So that is the reason.
Another question for
does the modification in diet decreases the potential reaction of ulcerative colitis, so the similar in Crohn's disease, and dietary modification in Crohn's disease is as effective as in ulcerative colitis, because the data reported is similar. From ulcerative colitis, the lot of data reported. From Crohn's disease, there is less data on prevention and that. And second is, when one community shifts from one place to western area, the potential ulcerative colitis will increase. And do you think dietary factor is the main factor, or other factors like hygiene hypothesis and other environment factors? They play a key role, and dietary factor is a secondary factor, because dietary changes do not occur very early. It takes many decades to change.
I think, sir, this is a good question, and this we will not have a one-word answer for this, and that's why I mentioned that you have to take into account the whole lifestyle change. But it is true that migrants are developing more IBD. In fact, second generation Indians in the US have a higher incidence of IBD than the US in the US. So we always thought that was a Western disease, but Indians first generation high, second generation much higher, and at a younger age. So it could be a combination. We are working in rural India now, and we are finding that diets have changed significantly. Environment, yes. So I think via the microbiota, this whole thing, more will evolve in this area as more work goes on.
Okay, I think we'll stop the discussion. Sir.
I will discuss with you over tea.
I think we'll stop here. We are running late already, but thank you so much for a wonderful session to all the speakers and interesting discussion. Thank you.
Thanks for the wonderful discussion. For our next session,